Thank you. Hello, everyone. Good evening or good morning, depending on where you are. My name is Frank from Wisonic Medical. You're also welcome to attend our Wisonic Global Dandelion program with a mission to widely popularize the point-of-care ultrasound utilization in medical practice, such as anesthesiology, pain management, MSK, intensive care, and emergency medicine, by in cooperation with different experts across the globe to do online webinars or in-person workshop trainings. So far, we have already completed over 700 webinars nationally and internationally since 2020, attracted over 180,000 doctors attended, received over 3.2 million reviews and comments. This time, we are honored to have invited 8 renowned MSK experts in the United States to participate in our program, MSK Ultrasound Webinar Series. In the upcoming 2 months, they will deliver a comprehensive webinar series about musculoskeletal, including lecture topics on orthobiologic therapies and ultrasound utilization in MSK practice, covering common body parts like shoulder, elbow, hand, wrist, hip, foot, ankle, and knee. Here, I would like to express our most gratitude to these 8 respectable experts. Thank you. So, I will show my screen to you and introduce our topics and our speaker and moderator today. So today is the first webinar of our MSK Ultrasound webinar series. We invited Dr. Ariana Demers as speaker and Mark Coaster as moderator to lecture with the topic on orthobiological therapies. Mark Coaster has abundant experience in MSK and ultrasound. He has MSK and cardiac diagnostic ultrasound work since 2008. Became ultrasound consultant since 2012 and the MSK instructor since 2014. He is member of several famous societies like American Registry for Diagnostic Medical Sonography Society and the Society for Diagnostic Medical Sonography. Moreover, he will be the regular moderator for all of the 7 webinars in this MSK Ultrasound webinar series. So, Mark, could you please introduce today's speaker, Dr. Ariana Demers?
Good evening, everybody. I'm going to share my screen here.
Okay.
I'll kind of get started in introducing you to the guest speaker for this evening. And let's see, there we go. Can everybody see my screen?
Not yet.
It's taking a little time here.
Okay, we can wait.
Let me know when you see it.
Okay.
Not yet, huh?
Not yet. Maybe you can try again.
Screen share, there it goes. It was working earlier. How about now?
It's okay, I can help you. if you like.
If you just want to put her screen up. Apparently mine's not working for some reason today.
I can help you to share the screen. Don't worry, it's okay. Here, can you see the PPT slide?
Not quite yet.
It's coming. There it is.
Here I am.
There you are.
Okay.
Little glitch this evening, but let me introduce you to our speaker tonight. It's Ariana Demers. She is DO and RMSK. She's board certified in orthopedic surgery and fellowship trained in sports medicine. Her practice encompasses athletes of all levels of accomplishment and all stages of life. She specializes in minimally invasive orthoscopic procedures to treat injuries of the hip, shoulder, knee, and ankle, as well as regenerative medicine. She is a current president of International Orthobiologics Foundation. She founded Restore Orthopedics and Sports Medicine as an orthopedic center where patients can get an unbiased diagnosis and complete discussion of their non-surgical and surgical treatment options, including orthobiologics, as well as orthopedic surgery. She takes an innovative approach to get patients back to their healthy, active lifestyle. She's also passionate about driving change in our healthcare system to improve the lives of patients and doctors. So let's welcome Dr. Demers on Orthobiologics.
Thank you so much for having me. Can you hear me okay?
Yes.
Yes.
Perfect. And then we'll just advance to the slides. I'm really excited to be sharing this with you tonight. And hopefully we can be able to learn a little bit and also figure out where we're going. You want me to share my own slides? I'm happy to do that. Frank, is that okay?
Not yet. Maybe it will need a few seconds.
Sure. Let's see here. I have just share my screen. Okay. Just quickly do this. Okay.
Oh, it's okay now.
All right, so we'll just go ahead and start this. Okay, so we'll just get started today. This is evidence-based orthobiologic therapies, including platelet-rich plasma, bone marrow concentrate, and adipose in 2022. I do have some disclosures. I am the president of International Interventional Orthobiologics Foundation. I also am an instructor for Interventional Orthobiologics Foundation, as well as Orthosono MSK Ultrasound. I have some objectives today. I'm going to be defining the orthobiologics that we're talking about, giving you some evidence.
Dr. Ariana Demers.
Yes.
From my screen, the PowerPoint presentation is just a part of the screen. Can you zoom it to the full screen?
I can give it a try. Can you not see it all?
I can see the PowerPoint. Oh, now it's okay.
Is that better?
It's better now.
Great. Okay, thank you so much for speaking up. We're also going to be talking about safety, as well as some legal considerations, specifically in the United States. It will not apply to other countries. And then also where we're using these orthobiologics, and then very specifics about the specific orthobiologics that we're talking about. So why orthobiologic therapies? I think the first thing that we want to talk about is we want to be using these therapies to either modify or reverse degenerative conditions such as arthritis. Additionally, there's been some disappointing current treatment outcomes. We know that knee replacement surgery has been less than perfect, and people are looking for other options. We also want to be using orthobiologics to enhance the natural healing process without surgery, or improve the healing process with surgery or through surgery. And then always we're trying to decrease the pain and suffering from the degenerative conditions of musculoskeletal disease. So what are we talking about, these orthobiologics? We have prolotherapy, platelet-rich plasma, bone marrow concentrate, and adipose-derived cells. I'm not going to be talking about prolotherapy today, but we will be covering the rest of these orthobiologic treatments. So what is platelet-rich plasma? You've heard all the hype, we've talked about it a lot, but clearly it's defined as a volume of autologous plasma that has a platelet concentration above baseline. Our normal platelet counts are between 150,000 and 300,000 and averages about 200,000 per ml. PRP is defined as 1 million platelets per ml, and this concentration is in a 5 ml volume of plasma. And you can take a look at Dr. Mark's work, which was revolutionary in defining what platelet-rich plasma is. We also want to talk about dose. And really, we want to know how many platelets per ml multiplied by the number of mLs injected in a specific area. And we'll be talking about how important this is a little bit later. So what is platelet-rich plasma exactly? So we take a sample of blood, we put it in centrifuge and spin it down on what we call the soft spin. And what that gives us is our platelet-poor plasma. The platelet-rich plasma is the middle layer, and then red blood cells are trapped at the bottom. We then extract that platelet-poor plasma as well as the platelet-rich plasma, and we can talk about double spin or single spin, but really we want that buffy coat, and the platelets are contained in that middle layer. I also want to talk about levels of evidence. We're going to be talking about evidence for use of platelet-rich plasma orthobiologics, such as bone marrow concentrate and adipose cells. And my friend and colleague, Dr. Don Buford, did a really elegant study showing that our level of evidence in the top 6 orthopedic journals, and they reviewed a number of different journals, and in 2018 and 2019, 1,400 articles, and showed that the average level of evidence was a level 3. So randomized, double-blind randomized controlled trial is a level 1 evidence, expert opinion is level 5, and the average level of evidence is 3 in the top 6 orthopedic journals. So that's going to be our baseline of what we're looking for evidence that this may be an effective treatment. So where are we with the evidence? Looking at knee arthritis, we have really impressive evidence with a randomized control trial, level 1, 610 people with PRP versus saline, showing PRP is better than saline for up to 60 months. And we had less chondral loss, or it is chondroprotective, up to 60 months, which is a really impressive study that I think really highlights why we need to be looking at these. We also had a meta-analysis of 30 randomized controlled trials. So when somebody tells you that we don't have evidence for platelet-rich plasma use, we need to remind them that we have 30 randomized controlled trials. This is level 1 evidence showing that PRP is better for knee arthritis versus placebo, versus steroid, and versus hyaluronic acid injections at 3, 6, and 12 months. What about hip arthritis? We have level 1 evidence, randomized controlled trials showing that 50% versus hyaluronic acid, 50% advantage to total hip. In patients with PRP treatment, only 15% of those patients advanced to total hip, showing that leukocyte-poor platelet-rich plasma delayed need for total hip at 2-year follow-up. We also see that we have a randomized controlled trial, PRP versus HA, showing that PRP functions better than HA for both pain and function and is durable up to 12 months. What about gluteus tendinopathy? We have some really compelling level 1 randomized controlled trial corticosteroid versus leukocyte-rich PRP. We have 80 hits, 40 in each group.
Recording
PRP
stopped. Recording in progress.
At least significant improvement by 12 weeks. And at 2 years, this significant improvement was sustained. Our corticosteroids gave improvement by 6 weeks. By 24 weeks, this was not maintained. And this is a common treatment. This is what people use for this gluteus medius tendinopathy or a trochanteric bursitis. This been used for a long period of time. And this shows that platelet-rich plasma injections are better. What about the JAMA Restore randomized control trial that concluded that PRP is not better than saline for patients of mid-grade arthritis? What this really shows is that we have to be more cognizant of concentration, of what the definition of platelet-rich plasma was, because when you really dig into this study, this showed a concentration of 1.2 times concentration from baseline. This is not even considered technically PRP. And that what we are looking at is a 1.625 billion platelet injection per week is insufficient to treat arthritis. And what this article really helped us understand is that dosing does matter, and that low dose, low concentration platelet-rich plasma, they are correct. It is not better than saline. So that helped us define the floor of what we're talking about for our dosing for knee arthritis for platelet-rich plasma. We also have uses for chronic MCL sprain. And this is been seen, it was actually an intra-articular injection weekly for 3 weeks. And this was, the pain was improved by 1 month. I think that in low-grade tendon and ligament tears, this has been shown to be helpful. For ankle arthritis, we have some level 2 evidence showing 6 months and 1 year follow-up. For tibio-talar arthritis, pain was decreased by 50%. Now, this isn't the same experience as our really amazing outcomes from knee arthritis and hip arthritis. However, even a single 30 cc injection can decrease pain by 50%, and that's clinically significant. We're looking at ankle sprains. We have grade 3, which is the worst, anterior talofibular ligament sprain, and treated with 6 cc's of reasonable dose PRP. And the PRP group was better from 1 month to 1 year. If we look at Achilles, this has been a really problematic area, treating it surgically, treating it conservatively. We're talking about non-insertional Achilles tendinopathy. And we saw that level 4 evidence at 50 months showed significant improvement for a leukocyte-rich PRP injection. And when questioned, 91% of patients would repeat the treatment. Additionally, there was no rupture seen. The 2017 Boson study was a level 1 randomized controlled trial comparing corticosteroids, saline sham versus platelet-rich plasma, and all 3 groups did eccentric training. This was a 24-week follow-up, which it appears that probably this is a limited or short follow-up, especially for Achilles tendinopathy. However, we did have improvement with both PRP and corticosteroids at 24 weeks. Saline sham injection did not improve, even with eccentric physical therapy. And that in the short term, corticosteroid was better. But I think if this would have been followed out, it would be very interesting to see if in the long term, platelet-rich plasma provided a more durable outcome. Rotator cuff tendinopathy and specifically partial thickness tears. This is really an interesting subject to me. And we see in 2020 intratendinous injection of 1 milliliter of PRP under ultrasound guidance showed a 70% success rate. And failures were predicted by either type 3 acromion or AC joint arthropathy. But this is a very small injection under ultrasound guidance intratendinous with a quite high success rate. think in 2021, PRP versus corticosteroid, PRP in tenderness and subacromial, corticosteroid was only subacromial. This is level 1 evidence of leukocyte poor PRP, 1.6 concentration with a 10 cc blood draw, showing pretty low concentration of platelets, but we still showed that PRP had better pain and function at 3 months, but all things were equal at 1 year. So I think again, this really clarifies that dosing matters, and we really have to be cognizant of where we're putting these orthobiologics, what the dose was, and was it sufficient. We also are talking about rotator cuff in 2021, randomized controlled trial, PRP versus corticosteroid injection for partial thickness rotator cuff tears. And this again was the Arthrex ACP leukocyte poor PRP. And this does show even low concentration PRP was better than corticosteroids at 6 months. Looking at lateral epicondylitis, Alan Mishra's study in 2013 was a landmark study showing that leukocyte-rich PRP plus dry needling versus dry needling alone showed improved success, 84% versus 68% success. And then this study in 2019 was a systematic review showing PRP is statistically and clinically better than the corticosteroid for lateral epicondylitis. What about UCL tears, our partial tears? These are our throwing athletes. And in 2021, with a level of evidence of 3, we had N of 50 and 64% were returned to throwing after 1 PRP injection. 10 patients had a second injection and 3 returned to play. So we had an overall return to play of 72% without surgery. These are when these are surgically repaired, we know that it has a very high return to play rate, but it takes about 20 months. So this is a significant issue in the rehab process. And if we can return to play 72 patients, those are 72%, those are all the patients that did not require surgery. Obviously, for complete tears and for multiple tears, we have to be more specific about what we're talking about here. So sorry about that screen. Looking at CMC or thumb arthritis, as well as carpal tunnel, we had a level 1 randomized controlled trial of 2 injection of PRP for 2 weeks apart for CMC arthritis versus steroid. PRP was better and lasted at least 1 year. Additionally, for carpal tunnel, this was a really interesting study. It was a level 1 randomized controlled trial in patients with bilateral carpal tunnel syndrome. And on one side, they had 3.5 mLs of platelet-rich plasma versus steroid on the other side. And PRP was better every time up to 1 year. We have some evidence for SI joint treatment, as well as caudal epidurals. We have level 1 evidence for leukocyte-rich PRP versus corticosteroid for our caudal epidurals, showing that number 1, leukocyte-rich PRP was safe, as well as leukocyte-rich being better than corticosteroid epidurals from 3 to 6 months. If you look at SI joint injections for SI joint arthropathy, PRP injections, so this is a level 3 ultrasound study that showed a 2-point pain decrease from 1 month to 1 year. And PRP showed a 10% functional improvement. This was fairly disappointing, but still, I think in patients who have SI joint arthritis, this is better than corticosteroid, which is what we're providing now. We have some randomized controlled trials for lumbar disc, intradiscal PRP versus contrast as control. This was done by Greg Lutz's group. And we know that PRP was better for pain and function at 2 months. And even at 1 year, it continued to be better than control. So as far as safety is concerned, there's been no major adverse events reported with an autologous blood-derived therapies. And reviews generally conclude there's an inherent safety because it's autologous. Additionally, the most common adverse event is short-term pain at the injection site. And usually this is attributed to the pro-inflammatory cytokine profile of PRP. Additionally, there has been concern for introducing bacteria into the injectate during processing, but PRP is inherently antimicrobial with white blood cell concentrations, and there's been no reports of infection after platelet-rich plasma or platelet lysate injections that have been published in the recent literature. Regarding USA FDA requirements, there are no FDA requirements, although the equipment used to produce PRP and the injections themselves have been cleared by the FDA. PRP injection procedure is considered investigational, and it has not been approved by FDA, but because this is a substance that's derived from one's own blood, it is not considered a drug by the Federal Drug Administration, and thus it is exempt from FDA regulations. So where do we use this based on evidence? I think there's overwhelming evidence to support platelet-rich plasma use in knee arthritis, in tendinopathy, and ligament partial tears. I think there's very good support to support use in carpal tunnel syndrome, lumbar disc disease, ankle arthritis, and ankle sprains, as well as CMC arthritis. There are some specifics that I wanted to touch on. There's this concept of leukocyte rich, where we keep the leukocytes versus leukocyte poor, where we filter that out. We did see that for intra-articular injections, we found a more favorable outcome with leukocyte poor PRP, as well as it provides a more anti-inflammatory effect with less pro-inflammatory cytokines. We also showed a leukocyte rich, showing a less favorable outcomes for synovial sites, specifically in AGSM in 2014. So conventional wisdom recommends leukocyte poor for intra-articular joint injections, leukocyte rich for the majority of other options for treatment, especially ligament tendon, those applications. When we talk about concentration, there is a number of ways to talk about concentration. There's a increased from baseline, a factor of X, and the problem with the X factor, 5X, 6X, 10X, is our baseline is variable. Not only is each individual baseline variable from time of day to day, the baselines are variable across patients. And so this is unfortunately not a reproducible way to measure the concentration. I think we do have to use cell counting, use a hemocytometer, and count platelet number for a minimum. And what we're really trying to do is look at minimum concentration for effect. If you don't have a hemocytometer, there are companies that you can send off for quality control mechanisms to be able to know if you're in the ballpark for your platelet-rich plasma concentrations. Our dosing is not agreed upon at this point. There was a most recent study in 2021 showing that 10 billion, a dose of 10 billion platelets is effective for pain relief and is chondroprotective in knee arthritis. So I think that while that may be, we're not at this point, we don't know if that's the ceiling, if that's the floor, but we do know that the 10 billion has been effective for pain relief and chondroprotective effect. We still, unfortunately, don't have a single classification system to be able to compare PRP studies and draw conclusions for our patients. It's imperative that if you're doing platelet-rich plasma research, we have to classify and report specifics on how the PRP was prepared, what dose and how it was quantified, and our technique of injection. We must collect data on all of our patients so we know what was useful, what is not useful, what our dosing is looking like. And we have to know what we're injecting to compare against literature for expected outcomes. We still have work to do, but the future is very bright. I'm going to be moving over to bone marrow concentrate. What is it? So bone marrow aspiration is considered BMA. Bone marrow aspirate concentration is BMAC or BMC. Bone marrow concentrate contains mesenchymal stem cells called MSCs, hematopoietic stem cells and HSCs, platelets, which contain growth factors and multiple cytokines. There are anti-inflammatory and immunomodulatory properties of bone marrow concentrate stem cells that can facilitate regeneration of tissue. Additionally, the BMC can enhance quality of cartilage repair by increasing the aggrecan content and tissue firmness. So we know bone marrow concentrate contains MSCs and HSCs, and we've heard all about MSCs being the most important cell to be able to know about. This is a rare cell. It's 1 in 10,000 cells in bone marrow. The majority of the cells are hematopoietic stem cells, making white blood cells, red blood cells, platelets. Together, they total about 18 million per ml of bone marrow. And this is very different than PRP. This is a mix of cellular components. We know it's much higher in white blood cells. It's higher in IRAP, interleukin receptor antagonists, interleukin 1, interleukin 8. And when we talk about MSCs, Arnold Kaplan, who is the gentleman who coined the term mesenchymal stem cells, has now come out and said, no, we don't want to call them mesenchymal stem cells. It's not the cell itself. We want to call them medicinal signaling cells instead. So MSCs that we are talking about are medicinal signaling cells. And why do we say this? Because it's been really clear in the recent data that it's more of a paracrine effect. Cell signaling within a discrete environment is how these cells are enacting and creating change. This is a nice summary looking at the difference between bone marrow aspirate on the left and bone marrow concentrate from two different companies versus whole blood and platelet-rich plasma. As you can see, the IRAP in bone marrow concentrate is quite significant and quite low in platelet-rich plasma. Our MSC content in bone marrow concentrate is higher and not present in whole blood or PRP. We have some TGF-beta and platelet-derived growth factor, much higher in bone marrow concentrate than bone marrow aspirate, as well as very, very high in platelet-rich plasma. We know that interleukin 1 beta and interleukin 8 are also elevated in bone marrow concentrate. So we have to also talk about how we best harvest bone marrow aspirate for our bone marrow concentrate. We know that there are reliable places, reliable sources of bone marrow aspirate for biologic augmentation. We have seen that probably the most reliable with the highest concentration is the posterior sacroiliac spine, then the ASIS, proximal tibia, proximal humerus. Best practice is to preload the aspiration syringe with 1 ml of heparin per 10 ml syringe. So that's 1,000 units per ml. We've seen that multiple sites, minimum of 1 centimeter apart, are helpful. Small aliquots of 5 to 10 mLs per pull with a quick pull gives us more MSCs rather than a slow long pull, which may give us more peripheral blood. Some people are recommending a 200 nanometer mesh filter to make sure that we filter out any bone spicules or other problematic issues. We then have the buffy coat layer and the platelet plasma, which are extracted. This is what we're looking at following a bone marrow aspiration. Our bone marrow concentrate is used with centrifugation, and this is a same-day process with minimal manipulation of our cells, which complies with our FDA requirements, which are minimally manipulated, homologous use, and using a 510K cleared device. As you can see, we have plasma on top, bone marrow concentrate in the middle, and then red blood cells at the bottom. Just another graphic to show how we're using centrifugation. We're drawing the plasma off the top, using the bone marrow concentrate as that middle layer, and discarding the RBC layer. So we have to talk about cell counting. So you have to know and be able to quantify what you have. We have a couple of ways to talk about this. We have the TNCC, which is total nucleated cell count, as well as this colony forming unit, or CFU. At this point, there's no linear correlation between the TNCC and the CFU. TNCC is something that you can do in your lab same day prior to injection. CFU is not something that you can do in your lab. It is a send out. You have to wait for the colonies to actually form. Additionally, each lab that you send your sample to will count CFUs differently day to day and different between labs. There is some evidence for TNCC greater than 400 million to have greater efficacy in knee arthritis. This was done by Dr. Chris Centeno in 2015. And so there are some numbers out there that you can kind of hang your hat on as minimums or goals, but there's still work to be done. We don't have full guidelines on dosing and cell counting, but we are working towards a more uniform way of applying these aspirates. You can use TNCC as a surrogate for counting, as far as knowing your MSCs. We have our BMA, which is 18 million per ml of bone marrow, our bone marrow concentrate. If we concentrated it at 6 times baseline, we're looking at 108 million per ml. If we dose 5 milliliters of BMC, we now then have 540 million nucleated cells. And that does fall above that 4 million TNCC as a dose response. He had a really nice study, 424 knees at 12 months, showing the VAS for patients treated above 400 million was 1.6 versus VAS or pain score for patients treated with counts below 4 million TNCC was 3.2. Looking at our evidence for bone marrow concentrate, we're looking at knee arthritis, and this is a nice single injection, 50% pain reduction at 1 year. Dr. Centeno level 2 randomized controlled trial versus exercise, showing multiple injections with PRP, platelet lysate, and bone marrow concentrate, showing pain and function improved and maintained at the 2-year mark. We know that Dr. Ans in 2020 showed a randomized controlled trial showing bone marrow concentrate versus PRP to be equivalent. But we really take a look at the concentration and we're concerned that maybe this was low concentration bone marrow concentrate. And so maybe, and then as well as the quality of the BMA draw. And so maybe what they found was that low concentration bone marrow concentrate may be equivalent to PRP. This has not been discussed as a high concentration bone marrow concentrate. We know from Dr. Hernigh's work that bone marrow lesions and knee arthritis, Dr. Hernigue just published this in 2020 showing level 1 data, 140 bone marrow concentrate intraosseous injections versus total knee done on the other side at 10-year average follow-up. He used 10 cc's intraosseous in the tibia, 10 cc's intraosseous in the femur, and we know that the bone marrow lesion was reduced by 50% at 2 years. And there was a risk of total knee replacement of only 1.2% per year. And on the other side, risk of total knee revision was 1% per year. So this was a really elegant study that showed that even at 10 years, you have approximately a 12% risk of total knee versus, which is a really very durable treatment for injection-based therapy without the risk of surgical intervention. We know knee arthritis in 2022, BMAC versus PRP, this is level 3 data, showed that BMAC was 30% better pain relief, 50% better function than PRP. These were small numbers, but this was clear. This is level 3 evidence. A bone marrow concentrate for knee arthritis, BMC versus PRP versus hyaluronic acid, showing that BMC was better than leukocyte-rich PRP and hyaluronic acid, and that leukocyte-rich PRP showed better outcomes than hyaluronic acid, but was not statistically significant in their study, that in their randomized controlled trial. If we look at hip osteoarthritis in 2021 versus microfracture with hip arthroscopy, VAS as well as function was better with BMAC. In rotator cuff, BMAC and PRP versus exercise for partial thickness rotator cuff tears. And we saw that both bone marrow concentrate as well as PRP tear decreased for both exercise and PRP at 3 months, but it was better, the ASES function was better with BMAC and platelet-rich plasma treatment. As far as safety is concerned, we have a 2009 looking at safety, as well as in 2013. We know that Dr. Herningue published in 2018 showing that a 30-year follow-up prospective randomized controlled trial of 125 adults showed no increased cancer risk, and there's significant evidence that this is quite safe. Where do we use this? I think arthritis evidence supports knee arthritis, hip arthritis, partial thickness rotator cuff tears. And when do we use this? It appears that probably when we have failures of platelet-rich plasma or more severe disease, this is an appropriate application for bone marrow concentrate. Specifics on bone marrow concentrate: exercise for 30 minutes can mobilize adult stem cells into the peripheral blood. Fasting for 3 to 5 days can improve the number of mesenchymal stem cells harvested. We do know that bupivacaine is cytotoxic at all concentrations and should not be used in bone marrow aspiration, harvest, as well as concentrate injections. Lidocaine is okay at low dose, 0.25%, and ropivacaine appears to not have effects on MSC viability. There are some recommendations to stop anti-inflammatories prior to harvest and after injection to allow for our normal response to, quote, our needle-based injury that we are providing to the tissue with our bone marrow concentrate. I'm going to move on to adipose. So what is this? This is lipoaspirate that is obtained with a simple tumescence anesthesia and manual lipoaspirate with a low-pressure syringe and harvesting cannula. We have some different types of adipose tissues. The microfragmented adipose tissue is obtained by resizing and reducing that lipoaspirate tissue by mechanical processing. The tissues are rinsed and washed to remove oils, residues, red blood cells, and debris. Next step is stromal vascular fraction. This is a heterogeneous population of various immune, precursor, progenitor, and stromal and stem cells. They're isolated from the lipoaspirate or surgically harvested adipose tissue with enzymatic dissociation, centrifugation, and filtration. And then if you go one step further, and then you have adipose stem cells. These adipose stem cells are plastic adherent, culture expanded from the enzyme digested stromal vascular fraction. So this microfat is adipose. It's the stromal cells that are preserved in its native niche. It consists of adipocytes, the supporting matrix, which provides structural support, as well as the endothelial cells, fibroblasts, pericytes, smooth muscle cells, MSCs, leukocytes, lymphocytes, among others. Microfat is typically 300 to 600 nanometers and is considered an autologous biologic substance that is toward healing and restoration and repair of tissues. This is harvested again under tumescence anesthesia with mechanical processing, simple point of care procedure. Cellular identity count and viability and sterility are not typically determined. And it is a heterogeneous makeup of cellular interest that is injected into an anatomical site, and then the pericytes are activated as our MSC. Pericytes are the cellular immune privileged cells that are on the outside of the vascular portions of this aspirate. This does meet USA FDA guidance of minimal manipulation. This does have preservation of the stem cell niche. Stromal vascular fraction is from the harvested lipoaspirate, and then it's processed enzymatically and then with centrifugation and filtration. The isolate usually has 500,000 to 2 million cells per gram of adipose, and adipose stem cells have 1 to 20% versus bone marrow constant versus the mechanical method. This is 1,000 times more cells than the mechanical methods, and this is about 500 times more cells than obtained from bone marrow. If we're talking about adipose stem cells, these are culture expanded from SVF. This is manufactured in accordance with the good manufacturing practices. And our culture techniques vary widely from fetal bovine serum to serum-free alternatives. And these ASC or adipose stem cells have the ability to differentiate into different mesenchymal cell lineages. It's similar to bone marrow concentrate MSCs, but they do hold their phenotype better over the culture passages. But this is definitely more than minimal manipulation, and so has limited use for clinical use at this time. So where's the clinical evidence? There's some pretty encouraging evidence for knee arthritis with SVF with a good track record. MFAT's encouraging. There's definitely improved pain and function, and cartilage has variable improvement as measured by MRI. And there's an increasing number of randomized controlled trials. Definitely there's limited research on meniscus, shoulder arthritis, rotator cuff, hip osteoarthritis, as well as chondral lesions, ankle arthritis, and Achilles. So there's lots of knee studies for adipose treatment. For MFAT, and we have all sorts. We have osteoarthritis for MFAT with HA and PRP versus MFAT, plus or minus PRP with MFAT, and MFAT versus BMC. We have NEOA with SVF versus HA, age over 80, dosing versus BMAC. And then we have surgery in NEOA. So MFAT plus arthroscopy, MFAT plus arthroscopy and partial medial meniscectomy, arthroscopy and adipose-derived stem cells, arthroscopy with microfracture with or without SVF, and obviously abrasion arthroplasty. So I showed, these are some of my favorite studies that I think are quite helpful. This is a randomized controlled trial in patients with early NEOA. They had 3 doses of HA and PRP versus a single MFAT. And it showed significant, both the PRP as well as the MFAT they lead to clinical and functional outcomes at 6 and 12 months, but it appeared that the MFAT had better Tanger and Koo scores as well at the 12-month mark. This is a randomized controlled trial, SVF in one side, bilateral NEOA, Calgar and Lawrence 2 and 3, with HA on the other side. And really, my favorite part about this is that, number one, the SVF treated knees showed significant improvement in a 12-month follow-up with VAS, WOMAC, and range of motion. But more importantly, that there was some significant improvement in articular cartilage in the SVF treated knees compared to those treated with hyaluronic acid. I think this is a really interesting trial that talks about aged patients over 80 with grade 2 to grade 4 OA. These are 36-month case controlled. We had increased improved pain, range of motion, walking, and decreased medication use. At the 2-year mark, only 6% of patients transitioned to total joint. And of those 2 patients, so 3%, had death after total joint. And so really there's clear benefits of SVF therapy in patients older than age 80 that are seeking a safe, effective, minimally invasive solution for their degenerative joint disease. We have a BMAC versus SVF showing, this is a systematic review of 472 patients. SVF showed significantly better improvement on pain reduction than BMAC, as well as clinical effect from BMAC and SVF was equivalent. And there's been a number of studies that show that SVF versus BMAC or MFAT versus BMAC, those functional outcomes are equivalent. When we look at arthroscopy and MFAT, we have 30 patients with diffuse disease, and we have a knee scope plus MFAT showing significant improvement, 83% improved in their VAS, 87% improved in their Tanger scores. When we look at shoulder arthritis, this is really something that is near and dear to my heart. We had 20 subjects and 18 patients with rotator cuff pathology and glenohumeral arthritis, and they were injected under ultrasound guidance, and they had significant pain score reduction from 7.9 to 3.7, which is really clinically significant at month 12. And we both had ES scores that improved from 33 pre-treatment to 66 at post-treatment at month 12, which is really quite a significant improvement. We have adipose-derived stem cell injections enzymatically prepared, showing 90% reduction for intratendinous injections of rotator cuff disease, 90% reduction in that bursal-sided defect. And the strength of the rotator cuff increased by 50% at the 2-year mark with high-dose treatments. We're looking at rotator cuff arthroscopic rotator cuff repair plus ADCS, which showed that this significant improvement in failure rate of 28% without the enhanced group and 14% failure with the enhanced group with adipose-derived stem cells. Looking at Achilles tendinopathy with SVF, these are level 2 randomized controlled trial, SVF versus PRP, single injection at 180 days. And as well as Achilles tendinopathy level 1 randomized controlled trial of leukocyte-rich PRP versus SVF injection. And really, at 6 months, both improved at 180 days, but SVF had a significantly earlier response. And that's why when I talked about platelet-rich plasma being measured at 24 months, at 24 weeks, I think this is a short follow-up for these orthobiologic treatments. From a safety standpoint, we know that the concerns regarding safety profile were highlighted by the study Joe et al., with primary outcomes being with safety and reduction. And this study concluded that this is safe. In the SVF trials, there has been no site-related malignancies at all in all of our SVF trials. So we also know that when compared lipoaspirate versus liposuction, lipoaspirate is a significantly with a factor of 100 to 1,000 times more safe than standard liposuction that is done commonly for plastic surgery. When we look at this knee OA, I want to go over this. We had the BMAC versus MFAT. We know that if you look at response by group, KL1 had 100% response, KL2 is 76% response, KL3 is 46%, and KL4 is 53%. So I think this is a really good study to show and talk to your patients about expectations. What's the chance that they're going to have a response? You know, if you have grade 3 and 4, there's a 50% chance that you're going to have a response. And this also highlights that there's no outcome difference, and that both BMAC and MFAT had significant improvements in pain and function, but no difference between BMAC and MFAT. So when do we use this? Severe disease, failed PRP, or need for structural support, because we know that we have that niche that is in housing our MSCs and as well as our perisites, so it can be used as a scaffold. I think it shows where we use MFAT as knee arthritis, rotator cuff partial tears. I think using SVF and adipose stem cells requires FDA clinical trials only in the US. There are promising outcomes, and this becomes really quite interesting and exciting for us to have the ability to quantify, know what our dose is, as well as bank and store samples for future use. And I think this is really quite exciting in our research and where our future is headed. So just to clarify, this is for US FDA guidelines on the human cells, tissues, and cellular and tissue-based products. Autologous means of the same person, and generally understood to mean tissue of the host will be grafted somewhere else in the same body. Minimally manipulated means processing that does not alter the original relevant characteristics of the tissue, and that this is related to the tissue's utility for reconstruction, repair, or replacement. And then homologous use, the repair, reconstruction, or replacement or supplementation of that recipient cells or tissues performs the same basic function or functions that were the same in the donor. And then the manufacture of the HCTP does not involve combinations of cells or tissues or other articles except for water, crystalloids, or sterilizing or preserving and storing agents. Regarding adipose and the FDA guidelines, MFAT is made through mechanical processing and washing, and this qualifies as a minimal manipulation under the FDA guidelines. The utilization of enzymatic processing requires a FDA biologic license application as well as FDA trial, and so this does limit clinical applicability at this time. Additionally, SVF and AS adipose stem cells must be registered as such and can only be used in an approved trial with appropriate oversight, as well as good manufacturing processes adhering to the same standards as other FDA manufactured drugs. As far as regulatory, how should you discuss MFAT to be compliant? You focus on the adipose tissue as used for lubrication, structural support, mechanical support, padding, and other structural functions that are consistent with adipose. And they may also have an added benefit of regenerative and anti-inflammatory potential. So conclusions supporting our orthobiologic use, I think PRP has overwhelming support for the use in knee OA, tendinopathy, ligament partial tears, and really good support for carpal tunnel syndrome, lumbar disc, ankle arthritis, and CMC. Regarding bone marrow concentrate, I think there's good support for use in knee OA, excellent support for knee bone marrow lesion, as well as hip and knee osteonecrosis, and partial thickness rotator cuff tears. Use for adipose tissues supported MFAT use in knee OA and the elderly. Promising clinical trials and outcomes for SVF and culture expanded. Definitely stay tuned, but this is not ready for prime time for clinical use today. There is a gap in our orthopedic treatment algorithms between corticosteroids and surgery. I think orthobiologics helps to bridge the gap, providing options that may improve healing, improve pain and disability without the same risks of surgery. So be the change and help bridge this gap. Thank you.
Thank you, Adrienne and Demirs. That was a great presentation on orthobiologics. I even learned a lot, and I've been sitting through a lot of presentations, and it's phenomenal how much information that you brought to the table today. And it's exciting to see what orthobiologics is doing for the healthcare of our individuals.
Yeah.
Soft tissue injuries and arthritis.
Right. It is, this is a really exciting time to be in medicine, and especially in MSK medicine, we are on the precipice of some really altering different ways of taking care of our patients. And we are at the forefront of what's happening. And it's just really exciting to be able to offer these treatments for our patients, knowing that the science behind it is very robust.
Absolutely. Well, we do have a few questions. Do you have time to take some questions here?
Yeah, absolutely.
Perfect. Let me read them off here. From Kemas, it says, good morning from Indonesia. Very great presentation. I have treated OA grade 2 to 3 with PRP in my practice. I have 2 questions. First question is, patients always complain about increasing pain 1 to 3 days after the PRP treatment. How do you treat the pain? Second question is, the result of PRP treatment in practice was not very satisfying. What do you think about that? Thank you.
Yeah, sure. So I think that the first question is how that he's experiencing the inflammatory findings after platelet-rich plasma injection intra-articularly, and that does exist, and we know that. And so in my current practice for platelet-rich plasma, you have to definitely note and educate your patients so that this is to be expected. This is not alarming. This is to be expected. This is an inflammatory process that is kickstarting the natural healing process, just like any other injury. And that really what we want to do is enhance the body's ability to respond to this injury and have that normal healing cascade. So I use different types of treatments. We can use heat, or infrared. We can use laser. We can use Tylenol or acetaminophen. I do not use anti-inflammatories. Sometimes if it's quite severe or more invasive, you can use narcotic medications for that 24 to 48 hour period. But I think for the most part, educating the patient that this is expected, that this is just like any other injury. And I think that helps set the stage quite nicely. As far as disappointing outcomes with platelet-rich plasma in your clinical practice, I'm going to go back to, we have to know what the dose was. We have to know where we're at. So without knowing where that dosing is, I think it's going to be really hard to clarify what the outcomes should be expected. So as we go along in our research and as we clarify in our research what that dose is, I think that we can be much more confident that it's either going to be helpful or not helpful. I thought that the research paper regarding how much they responded, 100% of grade 1 knee arthritis responds to either BMAC or SVF, and only 50% of the KL3-4 responded. There's been another study that was done a couple of years ago, I think in Germany, that's talked about that it's a dosing problem. Response is a dosing problem. And they did a really nice trial where they broke it down and took those non-responders and redosed them and transitioned the non-responders into responders at a very high rate. So I think as we go along in our research, I think the dosing and response rate is going to be really important.
Kind of going back, I'm going to kind of ask a question here for you. Going back to his first question with the pain. Now, that could be single spin or double spin, correct?
Mm-hmm. Absolutely.
Yes.
Yeah, because the difference between the single spin and the double spin, right, is the single spin isolates that platelet-rich plasma, the buffy coat, but also has all that platelet-poor plasma in it. So it's going to be a lower concentration. And so if you then take that and do it at a double and then spin it again. So you take the platelet poor, that suspended solution with all of the platelets and the platelet poor plasma, and then you spin it again at a higher rate for a longer period of time, and you get all of the platelets in pellet form at the bottom, and then you have platelet poor plasma. Then you can draw off all your platelet poor plasma, you have your pellet form, and then you can decide concentration. So ultimately, I think what you have is that you have these inflammatory mediators in your plasma. And so it depends on what you're going for, what your concentration of platelets, but this doesn't negate the fact that you have your inflammatory cytokines. This is a cytokine mix that we haven't fully characterized. And so we're still looking at these things. Is it the platelets? Is it the IRAP? Is it the interleukin 8? Is it the interleukin 1? We don't have all the answers yet, but what we do know, there are a lot of things that we do know, and that I think is helpful for us. But yeah, it's still inflammatory mediated. And when you're talking about concentration of platelet-rich plasma, the higher the concentration, you have to, by design, you're still going to get more white blood cells, because it has to do with concentration of platelets. If you're concentrating the platelets 20 times baseline, even if you're filtering out the majority of white cells, those white cells that are still in there are going to be higher because of the concentration.
Sure, great answer. Okay, next question is from, let's see here, for interdiscal injections.
Yeah.
Do you prefer PRP or bone marrow?
Well, so I don't do interdiscal, but I do know that there are a lot of discussions about PRP versus bone marrow. And ultimately, I think that those are two very different things, two different entities altogether. And I think you have to be clear what your end goal is, and how much invasion you're really looking at, and how much improvement the platelet-rich plasma injection versus bone marrow concentrate injection is giving you. Is it worth the risk? Is it worth the cost? You have to make sure that the risk outweighs that, or the benefit outweighs the risk. And I think that there's been some really interesting studies. I know the study from Greg Lutz's group showed some really fascinating things, of which the most concerning and fascinating is that maybe the interdiscal environment is not sterile. And additionally, this may also be affected by your gut microbiome. All of these thoughts and all of these interplays between gut microbiome, inflammation, intradiscal environment not being sterile, and that we know we can culture out bacteria from an intradiscal biopsy is concerning. So I know Dr. Lutz is recommending for sure the leukocyte rich, and we know that bone marrow concentrate has very, very high white cells. And so I think this will play out in the near future, what the recommendations are going to be going forward for interdiscal.
Sure, appreciate that. Next question is by Luck. Hi, doctor. For use of BMAC, do you recommend using a single or double spin when processing for injections?
Well, ultimately, I think you have to make sure that you know what you're concentrating. And I think in order to make sure that you are getting the most concentrated milieu with the highest number of cells, because we do know that you can use the TNCC as a corollary for dosing. I think that you want to make sure that you're not diluting out your bone marrow concentrate. So I would advocate that no matter what you're doing, go ahead and look at your TNCC, because I think what you're going to find is the double spin is going to give you a higher TNCC than the single spin with diluted out with your plasma.
Okay. Another question here. Do you use PRP or bone marrow on your orthopedic surgeries?
Yeah, so that's a great question. It depends on what I'm doing, but I think that the literature would support For rotator cuff repair, that I think bone marrow concentrate is going to show us significantly decreased re-tear rate versus using it alone. And that has not been borne out with the studies for PRP. Additionally, there is a lot of concern about when we're doing arthroscopic surgery, washing away all of the growth factors. So a lot of surgeons will use the activated platelet-rich plasma to actually make a clot to be able to sew it in instead of liquid PRP.
Perfect. Another question here. Do you recommend using BMAC with a joint capsule? Example, shoulder, knee, hip?
So I think what he's, or she, is talking about is maybe for capsular laxity or capsular injury, do you use platelet-rich plasma versus bone marrow concentrate? And I think, from ease of use and from risk, I think platelet-rich plasma can get a lot of work done. I think it's in my practice, it's a workhorse, and it's a majority of my patients use platelet-rich plasma. And then those who either fail or have more severe disease may be candidates for either adipose or bone marrow concentrate.
Sure. I have one last question here. It's kind of off the cuff here. We didn't really talk about it much.
Sure.
But do you use exosomes in your practice? If so, why or why not?
So number one, I don't use exosomes in my practice, and currently they are not legal to be marketed to physicians since the end of I think last year when the FDA actually started enforcing compliance. So if you're using exosomes, keep it to yourself or don't, please.
Well, that's all the questions that we have for this evening.
Great. Well, thank you so much for Wisonic for having me. I really appreciated the opportunity to show that this is the future, and I think the future is bright.
Thank you so much, Dr. Demers. On behalf of Wisonic Medical, thanks for your presentation. Again, it's excellent.
Thank you so much. We really appreciate the time.
Yeah, we want to cooperate with you again in the future for next webinars.
Great.
We'll keep in touch.
All right.
And Mark, also we thanks a lot for your efforts as well.
Very welcome. Thank you for inviting me.
Okay. So everyone in the room, thank you for your watching today. I would like to invite you to join our webinar on next Tuesday again. Dr. Michael Moe will present the second webinar with the topic on ultrasound in MSK practice shoulder. Let's stay tuned.
Thank you.
Thank you. See you.
Thank you, everyone.
Thank you.